Okay, let's unpack this. Welcome to another deep dive. Today, we're looking at a truly classic condition, one that's absolutely fundamental for revision, especially if you're prepping for something like the MSRA exam. We're diving into Pellagra. We've got a body of detailed information right here, and our mission really is to cut straight to the chase, pull out those essential must-know facts, and make sure this diagnosis really sticks for you. It's a historical disease, no doubt, but it's far from obsolete. It definitely shows up in specific populations and situations today.
And that's exactly why it's so important to understand. Pellagra is a perfect example of how a single nutrient deficiency can ripple outwards, causing widespread, systemic problems throughout the body. Thinking about it helps you understand nutrient roles, metabolism, and how quite diverse symptoms can link back to one root cause. And the best part for revision, it gives us that incredibly memorable hook right at the start, the classic 4Ds.
Absolutely. The 4Ds are your mnemonic life raft here. So let's start with the absolute basics. What is pellagra, and where does it come from? At its heart, it's a nutritional deficiency disorder. The key missing piece, niacin, which is vitamin B3. And as you said, the classic severe presentation gives us dermatitis, diarrhea, dementia, and in untreated advanced cases, death. Just locking those four in your memory is, well, half the battle.
So the primary cause is pretty straightforward. You're just not getting enough niacin from your diet. Niacin comes in a couple of forms, nicotinic acid and nicotinamide, found in foods like meat, fish, poultry, legumes, grains, and you'll often see it added to enriched flour.
Right.
But there's a fascinating twist, isn't there? Your body actually has a backup plan.
It does. Tryptophan, which is an amino acid you get from protein, can actually be converted into niacin by your body. It's like a second pathway. But this is where things get really interesting, especially for exam purposes, because this conversion process can be blocked. And the most notorious blocker, the one you absolutely need to remember, is a specific drug, isoniazid. If someone is on isoniazid for something like TB prophylaxis, it can inhibit this tryptophan to niacin pathway. So even if they're getting enough tryptophan, they can still develop a niacin deficiency.
Right, that's a classic high-yield association. So it's not just dietary lack, but also things that mess with that conversion or crucially affect absorption. If you're eating plenty of niacin and tryptophan, but your gut just can't pull it out of the food, you're still going to be deficient. This is where conditions like alcoholism and certain gastrointestinal disorders come into play as major risk factors.
Okay, so that gives us the what's and the basic why. Let's talk about the who and the where. Who are we actually seeing with pellagra today, and in what circumstances? The obvious group is anyone with a significantly low niacin diet or general malnutrition. That's the major driver globally, particularly in areas facing food insecurity. But even in places with generally adequate food supply, there are specific vulnerable groups.
Exactly. Beyond simple dietary lack, the information we have highlights several key risk factors that concentrate cases. Alcoholism is a big one, often associated with poor diet and impaired absorption. Those GI disorders we mentioned, like Crohn's disease or celiac disease, can interfere with nutrient uptake. And again, that medication, isoniazid, critical to remember.
Definitely.
Poverty is an underlying factor that often links to poor dietary choices or limited access to nutrient-rich foods. And historically, and still in certain regions, diets heavily reliant on corn are a particular risk.
And understanding why corn-based diets are a problem is important. Our sources explain it's twofold. Corn is natural, relatively low in available niacin.
Right.
And the niacin it does contain is chemically bound in a way that makes it difficult for our bodies to absorb unless the corn is processed in a traditional method called nixtamalization, using an alkali like lime or lye.
Which many modern corn products aren't.
Exactly. So even eating a lot of corn doesn't guarantee adequate niacin unless your diet is diverse or the corn is fortified.
So, in terms of where you'd see it today, in a country like the UK, clinical pellagra isn't common anymore, largely thanks to better nutrition and food fortification programs that started decades ago. But you absolutely still need to know it because it hasn't disappeared entirely. Cases pop up almost exclusively in those vulnerable groups we listed. Chronic alcoholism, severe eating disorders like anorexia,
Okay.
certain rare conditions that mess with tryptophan metabolism like Hartnup's disease or Carcinoid syndrome. There's also a growing concern about very restrictive modern fad diets that cut out entire food groups without careful planning.
Right. That's a good point.
So while no longer a mass public health issue here, recognizing those specific risk contexts is vital for practice and exams.
That makes sense. Rare but relevant in specific situations. All right, let's get into the nuts and bolts. Pathophysiology and clinical features. How does not having enough niacin actually cause all these seemingly unrelated symptoms? This is where the biochemical side comes in, but let's keep it high level. Niacin is absolutely essential because it's converted into two crucial coenzymes, NAD and NADP. You don't need to draw out the pathways, but understand what they do. They are fundamental for a huge number of metabolic processes in every cell of your body.
Energy production.
Exactly. Energy production, making steroids and fatty acids, and even repairing your DNA.
Think of NAD and NADP, like the essential currency or maybe spark plugs needed for your body's entire factory to run. Without enough niacin, these spark plugs misfire or the currency runs out and different systems start breaking down. This is why you get problems affecting organs with high energy turnover, like the skin, the gut, and the brain.
Okay, so now let's unpack those famous 4Ds in more detail and look at the other signs.
The dermatitis is often the most visually striking. It's characteristic because it's symmetrical, appearing on both sides of the body in similar patterns, and typically develops in sun-exposed areas.
Right, sun exposure is key.
Yeah. It starts as redness, erythema, progresses to scaling, and often becomes hyperpigmented, meaning the skin darkens. Our source highlights some classic patterns that are great for memory and potential exam questions. The gauntlet of Pellagra, which is a band-like rash on the back of the hands and wrists, and Casal's necklace, a similar rash around the neck. Seeing these should immediately make you think of Pellagra.
Casal's necklace, definitely one to remember. Okay, then you have the diarrhea.
Yeah, this is often chronic and significant, not just mild loose stools, and it unfortunately contributes to further malnutrition and difficulty absorbing nutrients.
Double trouble then. And dementia.
Well, dementia here covers a range of neurological and psychiatric symptoms. Confusion, memory impairment, depression, irritability. It can be quite broad.
Okay. And finally, that fourth D, death, is the grim outcome if the condition is severe and not treated.
But it's really important to remember that it's not just the 4Ds. There are often earlier or associated symptoms listed in the information we have.
Like warning signs. Sort of, yeah. Keep an eye out for less specific things, like loss of appetite, general weakness, abdominal pain, and vomiting. These can be warning signs before the full-blown 4Ds manifest. There are also specific changes to mucous membranes, inflammation of the mouth, stomatitis, a characteristically bright red, sore tongue, glossitis, and inflammation of the esophagus or vagina, esophagitis, vaginitis. Other potential neurological signs mentioned include seizures and tingling or numbness paresthesia.
Wow, okay.
All these diverse symptoms, from the skin to the nervous system to the gut lining, underline that fundamental problem with energy metabolism and cellular repair caused by lack of NAD and ADPP.
Right, it really is a systemic problem. So given this range of symptoms, how do we actually diagnose it? And most importantly, how do we fix it? Diagnosis often starts with a high index of suspicion based on the patient's story and their risk factors, someone with a poor diet or alcoholism, or on isoniazid, presenting with some combination of the 4Ds or those other symptoms.
A thorough dietary history is crucial. Absolutely. Standard blood tests might show non-specific things like anemia or electrolyte imbalances secondary to malnutrition and diarrhea, but they don't confirm niacin deficiency directly.
No, they don't nail it down.
Niacin blood levels themselves aren't always the most reliable diagnostic tool because they can fluctuate. What is more specific, as the sources highlight, are tests looking at niacin breakdown products in the urine. Measuring levels of metabolites like 2-pyridone and 2-methyl-nicotinamide can indicate functional niacin status.
Those urine tests are quite helpful.
Yeah, and also looking at NAD and NADP levels within red blood cells can be a useful indicator. These specific metabolite tests are definitely worth remembering for revision.
Good point. Once you've got that high suspicion and perhaps initiated investigations, the treatment is, thankfully, quite simple and very effective. Replace the missing niacin.
Straightforward enough.
Exactly. The cornerstone of management is niacin repletion. This means dietary changes, encouraging foods naturally rich in niacin or tryptophan, meat, fish, fortified cereals, and generally improving overall nutrition. Alongside that, supplementation is key, especially if symptoms are present. The recommended form is oral nicotinamide.
Nicotinamide, not nicotinic acid.
Right, usually nicotinamide, often given at doses like 100 to 200 milligrams 3 times a day. It's important to use nicotinamide over nicotinic acid for treating deficiency because nicotinamide causes significantly fewer side effects, particularly that uncomfortable flushing sensation that nicotinic acid is notorious for.
Ah, the flushing. Okay, that makes sense.
It's encouraging that symptoms often start to improve quite quickly once treatment begins. The skin changes might show signs of healing within, say, 24-48 hours.
That's quite fast.
It can be. The notes mention that adverse effects from nicotinamide at these doses for deficiency are usually mild. The more serious potential side effects you might hear about, like flushing, liver problems, hepatotoxicity, or effects on blood sugar, are generally associated with much higher doses of nicotinic acid when it's used for different purposes,
Yep.
like treating high cholesterol,
Okay.
or sometimes seen with very high doses of nicotinamide. Food sources are completely safe and don't cause toxicity.
Good to know. So let's put it into a quick scenario you might face. Imagine you're seeing a patient, perhaps an elderly individual, with a history of long-term, complex health issues that have affected their appetite and diet for months. They present with a patchy, sunburnt-like rash on their arms and face that seems to be getting darker. Their family says they've become increasingly forgetful and confused recently, and they've been having persistent diarrhea. Based on what we've just discussed, what diagnosis should be high on your list, and what's a crucial initial step in management?
Okay, so skin changes, sun exposed, neurological stuff, diarrhea, and risk factors for poor nutrition.
Yeah.
Given that combination, Pellagra should be strongly considered, high on the list. And your crucial initial step while arranging investigations would be to start oral niacin supplementation, specifically nicotinamide.
Perfect. That scenario really brings the 4Ds and the risk factors together. Finally, let's quickly touch on differential diagnoses. What else could mimic this? And then prognosis and complications.
Right, because the symptoms are so broad: skin, gut, brain. You absolutely need to consider other conditions. Other nutritional deficiencies, particularly B12 deficiency, can cause neurological or GI symptoms. Various digestive disorders, like severe celiac disease or inflammatory bowel disease, could cause diarrhea and malabsorption, potentially leading to multiple deficiencies. Even certain psychiatric conditions might present with confusion or depression that could overlap with the dementia aspect. A careful history, looking for those specific rash patterns like Casal's necklace, and targeted investigations are key to sorting it out.
Makes sense. And if someone is diagnosed, what's the likely outcome? What happens if it's treated versus left untreated?
The good news is, the prognosis with proper treatment and correction of the niacin deficiency is generally excellent. Symptoms usually improve significantly over weeks to months once niacin levels are restored.
That's reassuring.
However, and this is why recognition is vital, if pellagra is left untreated, the prognosis is poor.
Okay.
Untreated, it can lead to serious complications. The severe diarrhea and poor appetite cause worsening malnutrition and dangerous electrolyte imbalances. The compromised skin can become infected, leading to secondary bacterial infections.
Right. Infections.
Prolonged deficiency can cause organ damage. And while the neurological symptoms often improve with treatment, the dementia component can sometimes lead to persistent cognitive impairment even after the deficiency is corrected.
So long-term brain effects are possible.
They can be, yes. So those 4Ds aren't just presentation, they're potential complications if ignored. Death being the ultimate outcome, dementia can become a long-term issue. Dermatitis risks secondary infection, and diarrhea fuels malnutrition and electrolyte problems.
That's a powerful way to link them.
And prevention, of course, is about ensuring adequate niacin intake, which is particularly important in vulnerable groups, and something specifically mentioned for pregnant women.
Right.
Pellagra often feels like a ghost from the past, associated mainly with historical poverty and famine. But when we look at the risk factors we've discussed today, alcoholism, specific medications like isoniazid, underlying GI diseases, and even modern restrictive diets, it raises a really interesting question. Where else might we be missing cases right now, perhaps in patients whose symptoms we're attributing to other things, even in relatively affluent settings, simply because we're not actively considering this classic deficiency?
That's a powerful thought to finish on. This deep dive into pellagra has hopefully given you the essential information you need for revision, understanding it as a niacin B3 deficiency, recognizing the key risk groups and triggers like isoniazid, having a grasp of why it causes systemic symptoms, NAD, NADP, locking in those classic 4Ds and their specific appearances like Casal's necklace, knowing which investigations are most useful like urine metabolites, and remembering the simple, effective treatment with oral nicotinamide.
Understanding conditions like this really reinforces how fundamental nutrition is to overall health and how important it is to consider deficiency as a potential cause of widespread symptoms, especially in vulnerable populations.
We hope this has been a high-yield session and helps you feel confident about pellagra for your revision. For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.